Hi, I'm Dan Kindler. I'm glad to be with you today, even if I'm not with you. Um, Today, I'm going to be talking about a topic I think is incredibly important. I actually think it's reaching epidemic proportions. So let's get started. I'm going to share my screen, share my PowerPoint, and blow it up. Pediatric acute onset neuropsychiatric syndrome, aka PANS, aka infection, autoimmunity, and mental illness. So here's what we're going to be talking about today. We're going to go through some case histories. I'm going to describe what PANDAS is and then what PANS is, describe what the Cunningham panel is. We're going to talk about tick-borne illnesses and psychiatric disorders. This is going to be a review of some stuff I talked about in a previous lecture, and that includes the pilot study we did. Then I'm going to get into the treatment of this disorder and what can we conclude. Okay, starting off with Maddie, 14-year-old female when I first saw her. Complaints since childhood. They include depression with dark intrusive thoughts, anxiety, phobias and panic attacks, OCD, constipation, enuresis, syncopal episodes, that's passing out, palpitations, heart racing, sleep disorder, drenching night sweats, chest pain, air hunger, muscle cramps, numbness, and paresthesias, which are tingling. Okay, so what happens if this young woman goes to her pediatrician with these complaints? Well, as soon as you see depression and anxiety, the assumption will be that all of these other symptoms are related to a psychiatric illness. But let's say we don't make that assumption. Well, now check it out. First of all, she has symptoms that clearly are from disturbances in the autonomic nervous system. These include palpitations, syncopal episodes, can include air hunger and chest pain and sweats. Okay, she has symptoms suggestive of neuropathy, numbness and tingling, and so on. Constipation and bedwetting, those symptoms are commonly caused by food sensitivities. Okay, so there's a possibility here that instead of all of these physical symptoms being secondary to a psychiatric illness, that the psychiatric illness is actually secondary to some organic problem. Okay, her physical exam is remarkable for POTS, that's postural orthostatic tachycardia syndrome. In other words, when you stand up, your pulse races, frequently resulting in lightheadedness and sometimes syncope. Prominent stria on her legs, arms, and breasts. So stria are reddish lines, which I will show you. And they are sometimes often confused with stretch marks. And memory loss, like, it was really hard getting a history from her. Mostly I was dependent on her mom. Laboratory was positive for Lyme disease, positive for babesia, which we'll talk about. It's a tick-borne co-infection with Lyme disease. And also we did a IgG test for food sensitivities, and she was positive to multiple foods. Here is a picture of the stria on the back of her legs. You can see these reddish lines. The reddish lines are actually caused by neovascularization of the tissue, new blood vessel formation. And this is diagnostic for Bartonella. Now I want to point out her Bartonella test was negative. I want to point out that Bartonella testing is incredibly insensitive, and we often make the diagnosis clinically, and the presence of these stria is pretty much a slam dunk for that diagnosis. Here's some stria on her arms. And here's her Cunningham panel. I'm going to come back and talk about this in detail, but she has really high antineuronal antibodies. You can see the anti-dopamine receptor D1, and then the anti-lysoganglioside, anti-tubulin are all markedly elevated. And she has increased activation of this enzyme, which I will come back to talk about, calcium calmodulin protein kinase 2. Case 2, Anna, 18 years old when I first saw her. As a child, she had sensory integration disorder, speech disorder, eye tracking issues, constipation, odd hand movements. This is like just these involuntary movements that are medically referred to as chorea or choreiform movements. Think of Huntington's chorea, where people have a genetic disorder where in later age they just have these abnormal movements. Facial grimacing, which is tics, and OCD. Okay, so this is all getting worse. As a teen, she also has a sleep disorder, depression, anxiety. She's manic at nighttime. She has headaches, joint pains with knee swelling, muscle aches, pruritus, which means itching, nausea, heartburn, sugar cravings, recurrent viral infections, pins and needles, numbness. She's labeled as atypical bipolar. Her physical exam is unremarkable, except she has dermatographia. So what is that? Dermatographia, literally, probably Latin, for skin writing. And what it refers to is if you scratch the skin, typically we'll do it on the forearm, just take a nail and wait 30 seconds or less, and classically a red line occurs. Or sometimes it's a white line, sometimes it's a white line in between red lines. But what it is, it's a histamine reaction. And this is indicative of abnormal mast cell activation. I'm going to talk about that. Okay, so Anna's laboratory showed she had a low thyroid. She also had a low morning cortisol, but this is really interesting. Her sleep pattern was such that around 11 o'clock at night, instead of getting tired, she would wake up. She not only woke up, but she was actually manic from midnight until 5 to 6 a.m. She was manic. Then she would collapse and she'd be sleeping until 2 p.m. Well, an endocrinologist tested her morning cortisol and it was low and said, whoa, you have some adrenal insufficiency, and put her on a low dose of hydrocortisone, all well and good. But I said, I think there might be a little bit more going on. And we got an 11 p.m. cortisol level and it was high. In other words, she had cortisol reversal. She had high at night, low in the morning, instead of the usual high in the morning, low at night. She had the cortisol pattern of someone who works the night shift. Okay, so in addition, we did MTHFR testing and she was homozygous for the C6-7TT allele. I'll come back to talk about that. But as some of you probably know, when people are homozygous for this allele, typically the homocysteine is high, but hers was low. And I bring this to your attention because I see this pattern in a lot of these kids. At least 75% of the kids I see with PANS have this pattern. I'm going to come back to why it's important to recognize. She also had a lot of mold toxins in her urine. And here was her Cunningham panel. Again, she was not as demonstrative as the previous patient, but you can see she had elevation in anti-tubulin body and in the enzyme CAM kinase 2. Okay, Heidi is case number 3, 14 years old. At 2 years old, she began with severe tantrums. Okay, 2-year-olds often tantrum, but these were violent. These were over-the-top meltdowns. She couldn't sleep, and then she had increasing depression, irritability with rage attacks, anxiety, OCD, cutting, isolating, eating issues, involuntary movements, chills, and sweats. Okay. Her physical exam, she showed superficial lacerations on her forearms where she had been cutting. She also had stria on her breasts and thighs, and she had a positive Romberg. This is important. So let's talk about what a Romberg sign is. If you put your feet totally together, so like this, so they're touching, and stand straight and close your eyes, you should be able to stay balanced with a minimal amount of sway. If you're a ballet dancer or a skater, there'll be zero sway. And people with a positive Romberg, they tend to fall over or sway big time. So what's the problem? Their problem is they're not getting appropriate proprioception information on the soles of their feet. It's actually a neuropathy, and it's classically caused by a deficiency of B12. Her B12, you can see, was 386. Anything less than 400 is suspicious. And if you're a strict vegan, that would make sense. But if you're eating meat, dairy, eggs, you should have plenty of B12 on board without any supplementation. She was not a vegetarian. So the problem is she couldn't absorb vitamin B12. And this leads to a whole host of problems that actually make Pan's problems worse. So basically, she needs to either get B12 injections, or she needs to get a supplement that has B12 plus intrinsic factor, which she's lacking, and that's why she can't absorb it. Okay, check out her methylation profile. So she has two mutations, two heterozygous mutations at the MTHFR gene. And so this is roughly equivalent to one homozygous mutation, right? Two heterozygous mutations. And she also has a low homocysteine. So here's her Cunningham panel. This looks very similar to Anna's, with high antitubulin, high calcium calmodulin protein kinase 2 activity. Let's talk about methylation a bit. So what we're looking at here is really just a fraction of the whole methylation cycle. Methylation is important for a huge number of reasons. It's important for neurotransmitter metabolism, for hormone metabolism. It's important for DNA regulation and repair. And it's critically important for detoxification. Methylation occurs in virtually every cell of the body. So let's get down to the nitty gritty. Here's our MTHFR enzyme coded for by the gene. And what it does is it converts folate in our diet. Folate's part of the B complex, but we get it naturally from foliage, right? Okay, so MTHFR converts folate to its active form, 5-methyl tetrahydrofolate. If you have two mutations here, it's actually going to slow this down 70%. So you can see this is going to go really slowly. And if that goes really slowly, this cycle will go really slowly. And what happens is homocysteine does not get metabolized up to methionine and SAMe. So we would expect an elevated homocysteine, but in these kids, we typically see a low homocysteine. That's because there is acceleration of the transsulfuration pathway, which takes the homocysteine south. How does that happen? Well, this CBS gene, if there's mutations there, what happens is it accelerates that enzyme. Well, this has really significant consequences. People say, well, homocysteine's low, that's okay, yeah? And the answer is no, it's not okay. Because now you're going to be low in methionine, low in SAMe. These are important for a number of reasons. And for a whole other reason, when homocysteine metabolism goes south here, there is a deficiency of glutathione. So low glutathione, low methionine, low SAMe, this is a very, very challenging detoxification cycle. And these people need to be supplemented with these, but you have to go slowly, because if you accelerate methylation too quickly, then suddenly the cells are going to be dumping metabolic toxins into the bloodstream faster than their kidneys and liver and so on can excrete them, and people will not feel well at all. So we have to go very slowly. I have a whole protocol for that in my book, which goes into this in more detail. Okay, what is PANDAS? Well, Susan Sweeto, one of my heroes, there are a bunch of heroes here, and frankly, they're virtually all females, which is, I think, is pretty interesting that they're tuned into this. Okay, so in 1994, neuropsychiatric disorders associated with group A strep infections. And basically she described some kids who are perfectly fine. They got a strep throat and then boom, they fell off a cliff. Suddenly they have anxiety disorders with OCD, other mood and behavioral issues. In 96, she described 50 children and she made up diagnostic criteria for the diagnosis of PANDAS. So she coined that term, pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. And then Murphy, another female, prospective study confirms that PANDAS is associated in fact with group A strep infection. She followed these kids prospectively. Okay, what are we seeing here? What we're seeing is immune cross-reactivity between microbes and host tissues, AKA molecular mimicry triggering autoimmune inflammation. So I'm going to digress for a moment because most people have heard of rheumatic fever. Rheumatic fever is when you get a strep infection, typically a strep throat, and the antibodies against the strep attack the heart valve because there's some structural similarity between the strep microbes and the heart valves. So in a sense, the immune system gets confused. Hey, these guys look alike, and starts to go after the heart valves. So it's an autoimmune reaction. Our immune system is attacking our own tissue, and it's an infection both. Well, what if these antibodies, instead of attacking the heart valves, attack our nervous system and our brain in particular? That's what we're talking about here. Children with PANDAS-like conditions exhibit elevated levels of antineuronal antibodies, and it's been demonstrated against dopamine receptors, lysoganglioside, and tubulin. Right, it's just what we see in the Cunningham panel. So here's what's happening. I'm going to be repeating myself. When antineuronal antibodies cross the blood-brain barrier, they can activate this enzyme, calcium calmodulin dependent protein kinase 2, which from now on I'm going to call CAMK2. It's a whole lot easier. So CAMK2 mediates many learning, memory, and developmental cell pathways. It alters dopamine transmission, which, as you know, is associated with neuropsychiatric disorders and the involuntary movements, these choreiform movements, suddenly just moving, different, it's involuntary. Okay, and now I'm going to repeat myself again. Group A strep infections lead to autoimmune encephalopathy by triggering antineuronal antibodies. I'm just going to mention, we can measure anti-streptolysin O, and we can measure anti-DNase B, and these are antibodies to strep, where we can see that our immune systems are reacting to these microbes. However, in fact, our immune system makes a whole lot of antibodies to these microbes, and most of them are filtered out by an immune system that's otherwise in balance. And particularly if there is a genetic disposition, then some of these antibodies don't get filtered out, and that's what happens. Some of these antibodies attack the brain. They become antineuronal antibodies. They cross the blood-brain barrier. They activate CAMK2, which increases dopamine, and then we have neuropsychiatric symptoms and these choreiform movements. Okay, what is PANS? Well, basically, it turns out group A strep is not the only microbe that triggers this. There's a whole host of microbes, and therefore they had to change the name, and they came up with pediatric acute onset neuropsychiatric syndrome instead of having strep in that name. I actually don't like this name at all, and I'll come back to why, but what we're talking about is the fact that there are a lot of different microbes that can trigger an autoimmune encephalopathy. So some experts got together in 2013 and they put together criteria for this diagnosis. Understand that criteria are important to understand and to make sense of what we're seeing in our patients, and particularly for people, researchers, to do studies, because if we're going to study people with PANS, we have to know we're talking about the same population. So we have to have case definitions or criteria. Here's what they came up with: the abrupt onset of OCD or severely restricted food intake, i.e. anorexia nervosa. No known medical or neurologic disorder that would account for the symptoms, and at least 2 of the following 7 conditions: anxiety, emotional lability, mainly depression, irritability, oppositional behavior, anger issues. These can be violent. Developmental regression, this occurs in kids, they actually lose, so really they start losing. Sudden deterioration in school performance, these straight A kids suddenly become C kids or worse. Motor or sensory abnormalities, tics and choreiform, the involuntary movements, grimacing, things like that. Somatic signs and symptoms, particularly sleep problems, bedwetting, or urinary frequency. Okay, microbes that trigger PANS. This is what we know so far. More will come up for sure, but look at all the viruses: herpes simplex, influenza A, varicella zoster, that's shingle, Epstein-Barr virus, HIV, and then look, SARS-CoV-2. No surprise, we know SARS-CoV-2 triggers. We know it triggers autoimmune problems, and it was just a question of time till it was documented that, among other things, it triggers autoimmune encephalopathy. I'm sure that if you looked at all these people with long COVID and started doing these antibody titers, which no one has done yet, at least no one has published yet, you're going to start to see a lot of those people with positive Cunningham panels. Okay, so in addition to viruses, there's mold. Just sensitivity to mold can also trigger PAN syndromes. Mycoplasma pneumonia and Bartonella Hensley. These are 2 very common tick-borne co-infections. That is, infections that we see in concert with Lyme disease. I'm going to come back to talk about them. Okay, what is the Cunningham panel? Madeline Cunningham, another hero. She developed this with lots of research. It consists of measuring 4 different antineuronal antibodies, as you can see here. 2 of them are anti-dopamine receptor antibodies, the anti-lysoganglioside and anti-tubulin antibodies, and the activity of CAMK2 enzyme. So Craig Shimasaki, with many other colleagues, did an elegant study that really demonstrated the utility of the Cunningham panel in the diagnosis of PANDAS or PANS. And so they took a bunch of patients who were diagnosed clinically, and they met 58 patients who met the inclusion criteria. So they met the strict definition of these conditions. And out of those 58, they were treated, and 34 of them got better or even resolved. 24 of them didn't get better or even worsened. All of them were tested before treatment and at the end of treatment. And basically, they found a very strong positive correlation between the symptoms, whether they improved or didn't, and the level of antineuronal antibodies and CAMK2 activation. In fact, the Cunningham panel had a sensitivity of 80% and specificity of 83% when correlated with the patient's neuropsychiatric symptoms. Okay, here's a little review part. Tick-borne illness and psychiatric disorders. Just a reminder: psychiatric conditions related to Lyme disease complex, and I'm using that term, Lyme disease complex. So I'm talking about people who have chronic Lyme, but they also have co-infections, other infections that they got from these little tick buggers. And typically they've been sick for a while and often have a lot of downstream consequences of excessive inflammation. So anxiety, agitation, panic attacks, depression, irritability, anger, etc. Those 3 are far and away the most common. They're not only the most common, they're there in the majority of my patients. And then check it out: OCD, phobia, schizoaffective disorder, bipolar disorder, eating disorders, anhedonia, alcohol, drug abuse, and other addictions, dissociative episodes. This turn out to be quite common. schizophrenia, personality disorders, suicide. You know, this is really sad, but the most common cause of death in Lyme disease, suicide. I want to talk about Lyme disease and PANS. So, you know, I just described all these symptoms of neuropsychiatric Lyme disease, AKA neuroborreliosis, and they parallel the symptoms of PANS. In fact, anti-neuronal antibodies are present in 50% of quote unquote PTLDS patients. PTLDS stands for post-treatment Lyme disease syndrome. That refers to patients who were diagnosed with acute Lyme disease. They were treated with acute Lyme disease with a relatively short course of antibiotics. They were presumed to be cured, and instead they went on to chronic illness. I hold that label PTLDS with disdain. It suggests that these people no longer have Lyme disease. Sadly, they not only also have Lyme disease, they also have co-infections, which is most likely why they weren't cured by that course of antibiotics. They had more than one infection, much harder to treat. Okay, turns out 50% of these people have anti-neuronal antibodies. And when we test for Lyme disease, we're looking at antibodies, and some of these antibodies are to outer surface proteins. And there's an outer surface protein A, and antibodies to that show up on band 31 on a Western blot or immunoblot test. That protein of outer surface protein A has a sequence similar to group A strep. Maybe this can also trigger autoimmune encephalopathy or PANS syndromes like strep can. In fact, outer surface protein A is associated with autoimmune reactivity. We know that. And people with a prior history of Lyme disease tend to have positive Cunningham panels. So the question is Lyme disease a trigger of PANS? And the answer is probably, but there are no documented cases where we're isolating Lyme disease, because all the people, I mean, I see a lot of kids who have Lyme and PANS, but they don't only have Lyme. They have Lyme, Bartonella, Mycoplasma, Babesia, and so on. So we can't indict Lyme disease itself as the trigger. So what are the co-infections? Well, I'm listing 7 of them here, but the first 3 are highlighted because they in particular tend to trigger neuropsychiatric problems, often severe neuropsychiatric problems. So this is from Rosalie Greenberg. She's a child psychiatrist in New Jersey. She described 27 youth who were referred to her with a diagnosis of pediatric bipolar disorder. Now, I know there's controversy about that diagnosis. I can't really weigh in on that, but these kids, mean age was only 7, 15 labeled as bipolar 1, 12 as bipolar 2, and basically she tested them all for tick-borne infections. And she found that 89% of them had 1 or more tick-borne pathogen antibodies. Okay, Babesia, Mycoplasma, Bartonella, and Lyme. And I just want to remind you that Babesia and Bartonella in particular, the testing has relatively low sensitivity. So we're probably missing some people. Okay, I want to talk about Bartonella in particular because Bartonella causes the worst that we see in patients in terms of neuropsychiatric problems, in terms of neurologic problems in general. But these have all been documented in the literature as being triggered by Bartonella: anxiety with or without panic attacks, depression, OCD, anger, rage, ODD. When these are severe, I immediately wonder, does this person have Bartonella? Phobias, substance abuse, personality disorders, psychosis, bipolar disorder, schizophrenia, schizoaffective disorder, and PANS. Bartonella has been shown to trigger PANS. This is a great study. Ed Breitschwert in North Carolina is considered, maybe the expert in Bartonella in this country and maybe the world, I don't know. Okay, so 33 patients they studied, they all had the recent onset of neuropsychiatric symptoms. And look at, here it is. These, like I said, these are the most common symptoms we see in this population: irritability or rage, anxiety or with or without panic attacks, and depression. And they had a smattering of other symptoms as well. Out of these 33, 29 had either antibodies or PCR, which is DNA evidence of Bartonella. That's really high. If you studied a control population, it could be as high as 10 or 15%. It would not be 29 out of 33. And, I need to point out that all of these infections could be asymptomatic in the right person. Usually when you put all these infections together, it's no longer asymptomatic, but there are patients walking around with Bartonella who are totally asymptomatic, and then they're not. So out of those 29, 24 of them had concurrent cutaneous lesions. So you guessed it. Most of them, they had Bartonella stria. And in a separate study where they biopsied the stria, they could see the immunofluorescence positive for Bartonella. And here's another picture of Bartonella stria. It looks like this person got whipped. It's very obvious these are not stretch marks. Okay, mycoplasma. Mycoplasma is, well, it's a very common respiratory pathogen. It's a bacteria, and it causes anything from colds, sore throats, ear infections, to bronchitis and pneumonia. Very common cause of bronchitis and pneumonia. But it also can trigger significant immune system problems, a lot of inflammation, and a lot of neurological problems. Here, I'm just listing the neuropsychiatric symptoms associated with mycoplasma. Check it out: acute psychosis, OCD, mania, eating disorders, and there are a few reports of mycoplasma triggering PANS. Okay, pilot study, 10 subjects in an adolescent residential treatment center. These were 10 kids just taken at random in this residential treatment center up in Estes Park, Colorado. And they were all diagnosed with major depressive disorder, 7 also with generalized anxiety disorder. 4 of them had made serious suicide attempts. And they did not have any known organic illnesses, with the exception of 1 that was diagnosed with celiac disorder. So they were all considered to have serious psychiatric problems. They couldn't hack it at home. They couldn't go to public school. And instead they were at this residential treatment center. So all we did was we tested them for antibodies to Lyme, Bartonella, tick-borne relapsing fever. It's confusing, but basically it can generate a Lyme-like illness. And then anti-DNase B, which is an antibody to strep, and the Cunningham panel. So I'm just going to summarize this by saying that there were definitive positives in terms of these people had antibodies that were consistent with exposure to these different microbes, and then probable, which is antibody pattern that suggested exposure but was not 100%. So here's a summary. Out of the 10 adolescents, severe depression and anxiety syndromes, 6 out of 10 had antibodies to tick-borne pathogens, Lyme, Bartonella species, tick-borne relapsing fever, consistent with exposure, right? We're looking at antibodies. That can only tell us, has this person been exposed? But depending on one's interpretation of these antibody patterns, 9 out of 10 had probable exposure to tick-borne pathogens. 3 out of 10 had elevated strep antibodies, and another 1 out of 10 had a borderline level of strep antibodies. But check this out. This is, I half expected to see those results in terms of antibodies to tick-borne infections, but this one blew me away. 9 out of 10 had elevated antineuronal antibodies consistent with PANS, with autoimmune encephalitis. 9 out of 10. So what do we do for PANS? Well, here are the major treatment modalities: antibiotics, anti-inflammatories, intravenous gamma globulin, psychotropic medication, psychotherapy, other immunomodulatory therapy. So let's break it down. We don't have any controlled studies, nor will we have any controlled studies. That's because, you know, we're not going to withhold treatment from these kids. An internet-based survey of 698 patients, over, basically 700 patients diagnosed, physician diagnosed with PANS. Out of them, basically they all got antibiotics, and then 50% or more got these different agents, and I'll go through them one at a time. Most effective was aggressive broad-spectrum antibiotics, duration greater than 30 days. Generally, the duration was much greater than 30 days. The most common antibiotics studied were beta-lactam antibiotics. These are penicillin derivatives, and azithromycin, which is Zithromax. Some of you might have had Z-Pax for strep throat or sinus infection. So the fact that these were the best studied, it does not mean that they're the best antibiotics out there, but they often are good antibiotics for PANS syndromes. Anti-inflammatories, at least somewhat effective in relieving symptoms. So ibuprofen or non-steroidal anti-inflammatory drugs, it can help. Not in everybody. Steroid tapers are frequently administered. I don't recommend it in this patient population because the steroids will not only suppress the immune system when it suppresses the inflammation, but by virtue of suppressing the immune system, these infections can flare. So there can be a temporary improvement, and then these kids get much worse. Antihistamines, I'm going to come back and talk about that in the context of mast cell activation. And IVIG, so now, everyone hears about monoclonal antibodies that we use for COVID. Well, monoclonal antibodies basically is a single strain of antibodies where they take the virus, the SARS-CoV-2 virus, and inject it into mice, and they derive antibodies from there. The IVIG is not a single strain of antibodies. It's a collection of antibodies from a lot of different people. There have not been any cases of this also transmitting an infection. So what you're administering are antibodies. And it's interesting that these antibodies will improve immune function and paradoxically also suppress inflammation. So it's been quite effective in many of these kids with PANS, particularly if these kids have a low IgG to begin with. Low IgG means they're not making antibodies appropriately, a condition called hypogammaglobulinemia. Unfortunately, the improvement is not always sustained. Sometimes they have to stay on IVIG, but here's the big problem with IVIG. It's administered usually intravenously, usually about every 3 weeks, and it costs $10,000, $13,000 a shot. Okay, most of us mere mortals really can't afford that, so we're dependent on insurance coverage, and no surprise, insurance carriers set a very high bar. And PANS by itself, does not get approved by insurance companies for IVIG administration unless you live in Illinois, where a progressive legislature mandated that insurance companies had to cover treatment for this condition. Okay, what else? Psychotropic meds, SSRIs basically were the most effective, but not always, and sometimes really negative effects. I'm sure you all know we give SSRIs to adolescents, and sometimes they become more suicidal. Psychotherapy, CBT, somewhat effective in these kids. Mainly, they need support. They need, they need help in understanding what's going on with their brain, because their reality is not consistent with what you and I would call reality, and it's a hellish reality that they're experiencing. Plasmapheresis, this is pretty aggressive stuff where basically they take blood out, filter antibodies, put the blood back. Most kids had initial improvement, but in 60% that response was not sustained. Plasmapheresis at this point is covered only for a rare cause of lymphoma. And there's a drug called rituximab. This is also a monoclonal antibody, results in B cell depletion, which actually can decrease inflammation. There are no controlled studies on this. In fact, I don't even think there are any reports. I'm simply aware of some practitioners who've used it with good results. Okay, Amiram Katz, he's a neurologist in Connecticut, Yale-trained, really good person. And he presented in 2015 at an ILADS conference, 112 patients that he saw who met the criteria for PANS. They also all had Lyme. They had IgM positivity to the outer surface protein A, in other words, positive band 31. They had these symptoms which met the criteria for PANS. On examination, many of them had involuntary movements. They tended, he did HLA testing. That's genetic testing. It's the same kind of genetic testing we do for organ transplant. And a significant percentage of them, a high percentage of them, had positive HLA-DR4, and that particular allele that is seen as a precursor for autoimmune illness. And, Amiram Katz, he's a neurologist, so he would study these kids, and they often showed evidence, objective evidence to peripheral and central nervous system on brain MRI, EMG, and or nerve conduction velocities. Okay, what he found was that the most effective antibiotic was long-acting bicillin. Now, most of you are probably too young to have witnessed this, but those of us who are my age or older, we get a strep throat, we get a shot of LA bicillin in our bums. Not happy about that. And that was it. That was the whole treatment because it was LA, it was long-acting. And he found that LA bicillin works best, particularly if you just give it by itself, don't combine it with other antibiotics. And these are at low doses. For example, we use LA bicillin in the treatment of Lyme disease, but we use higher doses than this usually. So you can see the dosing that he used. He found that it was more effective than intravenous antibiotics or corticosteroids. And he said, well, if the LA bicillin is not effective after 10 weeks of 1 shot per week, then he goes to IVIG, assuming he can get it approved. I will say that there are a whole lot of other things one can do besides going from LA bicillin to IVIG. Let's talk about some of those other things. Mast cells. So mast cells are involved with a lot of autoimmune illnesses. Mast cells are white cells. They are primitive white cells. Early on in our evolution, we developed mast cells. And they, originally their role was protection. They would fight, anything breaking our boundary. And now they contain about almost 200 different inflammatory mediators, like histamine and a whole bunch of cytokines. And when they get triggered, they degranulate. Basically, they release these mediators. And they can cause or make worse all these autoimmune illnesses. But also, they can cause a lot of syndromes we recognized as allergies, anything from hay fever and eczema and hives to anaphylaxis, but also can cause inflammation in a lot of different places that can manifest with migraine headaches, with joint pains and muscle aches, with fatigue, with diarrhea, and so on. So mast cell activation can in fact make autoimmune encephalopathy a lot worse. And if anything we can do to decrease the tendency of these mast cells to degranulate and release their contents, then is beneficial. So, I mentioned way back the test that, of dermatographia, and that's histamine. That histamine is causing that release. Histamine is one of the mediators released by mast cells. And so we use antihistamines to block histamine. And remember that we're talking about reactions that go way above and beyond typical allergies. H1 blockers are the antihistamines you hear about, and tons of them out there. H2 antihistamine blockers are actually gastric acid suppressors, and these can also be very helpful. Diamine oxidase. Diamine oxidase is an enzyme that metabolizes histamine, and some people are low in diamine oxidase, and supplementing that can be very helpful. Leukotriene inhibitors. Leukotriene is a cytokine that causes extreme inflammation, 1,000 times more so than histamine. And there are drugs which actually block leukotriene, like Singulair, which is routinely prescribed for asthma. Diet, I'm going to talk about diet some more, but in terms of mast cell activation, there are low histamine diets, as well as removing foods that trigger mast cell activation. I can tell you it's very different from one patient to the next what seems to trigger these mast cells. And there are agents we can give people that actually tend to stabilize the mast cells so they have less tendency to degranulate. That is the threshold by which they are triggered and release their inflammatory contents goes up, and they're less likely to do that. So these include quercetin. Quercetin's a bioflavonoid, works with vitamin C. It occurs naturally in the rinds of grapefruits and oranges, and that white stuff we typically peel away. It's a mast cell degranulation inhibitor. Ketotifen can be obtained at compounding pharmacies. Cromolyn is available as gastrochrome in your regular pharmacy. All Clear comes from quail eggs, believe it or not, also helps to stabilize mast cells. So here's a summary of treatment. What are the things we do for PANS? Well, antibiotics, and I've already mentioned LA bacillin, but there's, cephalosporins tend to also work on cell walls. Azithromycin, again, these are the best studied, but it doesn't mean they're the best drugs. For example, neither of those are going to hit Bartonella very well, and neither of them are going to hit Babesia very well. And there are other drugs that we might even use for mycoplasma and so on. So those are simply the drugs that are best studied. Anti-inflammatory agents, I mentioned non-steroidal anti-inflammatory drugs. CBD can be very helpful, particularly for anxiety, but CBD decreases neuroinflammation. And natural anti-inflammatories like omega-3 essential fatty acids, boswellia, curcumin, and PEA. IVIG, I've discussed, actually has the paradoxical impact of supporting the immune system and at the same time decreasing inflammation and treatment of mast cell activation syndrome. Okay, there are other treatment considerations. These kids develop hypersensitivity syndromes. Once there's this autoimmune reactivity, then people become sensitive to a lot of things, particularly foods. I can tell you that really the majority of my patients with PANS also have food sensitivities. The most common food sensitivities would be gluten, dairy, eggs, yeast, and corn. Those are the most common. They're not the only ones, okay? Mold issues, again, before PANS developed, might have been no problem, but once they develop this autoimmune and then hypersensitivity condition, now mold in the house, oh my God, big trigger. I just saw a kid last week. He's actually psychotic now But when he gets out of the house for a couple of weeks, he's much better. Goes back to the house, much worse. Mold is not his only issue, but it has become one of his triggers. Low dose immunotherapy, I'm not going to go into a lot of details on this. Basically, it's treating these bugs as if they were allergens and neutralizing them with shots or extract given under the tongue. Low dose naltrexone. Naltrexone is related to Narcan, which blocks opiate receptors, right? We give it to people with opioid overdoses. Well, the idea behind low dose naltrexone is that if we partially block those receptors, we can increase endorphin synthesis. It turns out that that's actually not what happens. What happens is we increase some anti-neuroinflammatory pathways. And for some kids, it really does help, can also cause sleep problems. So you have to be careful with it, but it's worth a try. And moving right along, multiple chemical sensitivities. Again, it's very common for these kids to develop sensitivity syndromes, not just to foods and mold, but also to chemicals. We're talking to perfumes and scents and candles, exhaust fumes, cleaning agents, dryer sheets are the worst. And some of them go on to electromagnetic field sensitivity. This is something that's not generally recognized, but in another generation it will be. Stress intervention. Well, this could be a big deal. We know that there's an association between stress-related disorders and an autoimmune disease. We know it goes both ways. That stress can trigger autoimmune problems, that autoimmune problems triggers stress. This is particularly in genetically prone individuals. There are some systems that really work on the limbic system of desensitizing the amygdala so that there's not this reaction to whatever is happening. And I don't mean just PTA, post-traumatic stress disorder, PTSD. I'm talking about a whole lot of inflammatory reactions in the body can get better if we are able to desensitize the limbic system. So the dynamic neural retraining system and the Gupta protocol both have been very helpful in people who are willing to go through the whole training to become desensitized. I've seen people with food allergies, chemical sensitivities, with mast cell activation syndromes, and Lyme disease get better doing these interventions. Polyvagal exercises. So the vagus nerve has a whole lot to do with immune reactions. The vagus nerve, I should point out, is the 10th cranial nerve. Classically, it affects the heart and the gut, but also it can affect swallowing, it can affect our lungs and our breathing, and immune activation and mast cell activation syndrome. And so there's basically different branches of the vagus nerve, and these exercises help to activate certain branches and suppress others, which can basically help people find some stability. There's a whole lot of books on this now. SSRIs, sertraline, I wrote is most effective. Well, it's really been the most tried, I think. And in my clinical experience, it seems to be better tolerated than most, but we know that the SSRIs can also be problematic. And sleep aids can be very important. Antipsychotics. I've seen at least a handful of kids who have frank psychosis consistent with the PAN syndrome. And then counseling, where CBT has been the most studied. I really think these kids need support, a whole lot of education to understand what's going on with them. And biofeedback, this is also something that we'll never get a controlled study on, but I know of some kids that have found it very helpful. Okay, folks, what can we conclude from all of this? Okay, well, we're start off, generally speaking, chronic manifestations of infection with Borrelia burgdorferi. This is the Lyme pathogen. Both post-treatment, meaning people who've been treated for acute Lyme disease but go on to chronic symptoms, and previously undiagnosed. They never saw a tick bite, they never saw a bullseye rash, but they went on to develop these chronic symptomatology, are associated with infection, persistent infection, and immune abnormalities. Patient with chronic Lyme disease complex have persistent infection with co-infections as well as Lyme. Just remind you that these ticks are a whole menagerie of different microbes. And patients with these persistent tick-borne infections often manifest hyperreactivity with autoimmunity. So they have multiple sensitivity problems, autoimmunity where they're attacking their own cells, as well as immune suppression. Okay, Lyme plus co-infections often presents with serious neuropsychiatric symptoms. I mean, it's not uncommon that these are the presenting symptoms. Multiple microbes are capable of stimulating cross-reactive antineuronal antibodies that result in autoimmune encephalopathy, PANS. So there are a whole bunch of microbes that we know of, and surely many we don't know of, that can trigger a PANS syndrome. Many patients with microbial-induced autoimmune encephalopathy do not meet the full diagnostic criteria for PANS. This is a problem that I alluded to previously when I said I really don't like that nomenclature of PANS. For one thing, it's often not an acute onset. It's sort of a stuttering onset or gradual onset of things getting worse, where you can't look back and say, oh, yeah, strep throat, then bang, acute onset. That's not what I usually see. Also, this is not limited to the pediatric population. At some point, I would love to be able to start running Cunningham panels on patients who have psychiatric hospitalizations. I actually wrote a paper and I suggested that we change the name from PANS to MANS, microbe-induced autoimmune neuropsychiatric syndrome. I think it really fits the bill. The Cunningham panel is a good marker for the presence of autoimmune encephalopathy. Okay, Bartonella species and Mycoplasma species. These two in particular have been documented as causing autoimmune encephalopathy. The vast majority of my patients with PANS have one or both of these pathogens. As yet, there is no documentation with Lyme by itself triggering PANS, and I don't think we're going to be able to provide that documentation. A significant subset of adolescents experience anxiety and depression. So I'm talking about 10 out of 10 of these kids with major depressive disorder so severe they had to be in a residential facility. 10 out of 10 have an organic illness with evidence of both tick-borne infections and autoimmune encephalopathy. Really, these numbers just blew us away. And does the same apply to adults? Right? Well, good question. Did we have those studies have not been done? So where are we going with this? Autoimmune encephalopathy, is it an epidemic? Is it related to other epidemics in the 21st century? So I'm not talking about the pandemic. I'm not talking about opioid overdoses to god-awful events. I'm talking about these epidemics that are really part of what's happened in the past century. So not just Lyme disease, and we also see more and more autoimmune illnesses, chronic fatigue syndrome, fibromyalgia, autism, food sensitivities, asthma, cardiovascular disease, adult onset diabetes, obesity, ADHD, and mood and behavioral disorders. I mean, check it out. Every one of these has gone way up in the past, just the past couple decades, not just the past century. So what's the origin of an epidemic? Basically, I want to make a case that I think all these epidemics are related. So an epidemic has a constellation of environmental factors, communicability, and susceptibility. And under susceptibility, the internal environment, we're talking about genetics, genetic predisposition, epigenetics, which I'll come back to, and developmental factors, meaning, well, this is the environment we grew up in, which is our nutrition, are we exposed to toxins, stress, trauma. I'm sure everyone here is acquainted with adverse childhood experiences and the impact it has not only on our psychological health, but also on our physical well-being. Okay, I'm going to come back to talk about epigenetics. So we know that genes don't change much except purportedly over millennia in response to natural selection. But there are proteins that sit on our genes and they turn the genes on and off. So it turns out that epigenetics can change from parent to child. That is, something can happen to a parent, it changes the epigenetics, and it gets passed down to that child, one generation to the next. Okay, so what are the changes we see in the past 100 years? There's changes in diet. We all know nutrient depletion, excessive sugar intake, oh my God, food additives, GMO foods. I mean, we all know that the diet of the average American is hugely different from what it was 100 years ago. This is an experiment happening in a very short amount of time. Exposure to xenobiotics. So these are chemicals we've never been exposed to before. In fact, there's hundreds of thousands of them. Herbicides, pesticides, formaldehydes, VOCs, households, fabric softeners, air fresheners, scented candles. If someone has multiple chemical sensitivity, they have a big problem negotiating even inside their home, let alone outside their home. I mean, you know, neighbors have their dryer vents, you know, basically these plumes of the fabric softeners that they put in their dryers. And my wife can't go outside when that happens. I mean, it just makes her headache, gives her a headache, makes her sick. And then there's EMF exposure. So I want to point out that every one of these can cause epigenetic changes. Diet, xenobiotics, electromagnetic field exposure, which obviously is going nuts. Okay, what else? Breakdown of community and social support. So we used to live in communities and extended families, then nuclear families, then single parent families. And now, sadly, really absent parents, homelessness. Basically, there used to be support networks. And I'm told, certainly we all hope it's true, that the incidence of sexual abuse is going down. God willing, that's true. But there was a difference 100 years ago, which is that when trauma was happening in a family, a kid often had aunts, uncles, grandparents that they could stay with. They were safe people. And now safety is lacking. Okay, I think this is huge, and it has a huge impact on our immune system, which is really not separate at all from our nervous system and so on. We know isolation results in depression. Anxiety and PTSD, they can be passed on epigenetically. In other words, something that happens to the parent and they get PTSD, that a kid can inherit that. So all these environmental factors that I've mentioned, from diet and chemicals and breakdown of community, all of these can result in epigenetic changes that are bequeathed to our progeny and then passed on to the next generation and are cumulative from one generation to the next generation. So just imagine a snowball here of epigenetic changes. And what do we see? Autoimmune issues are also passed on epigenetically. And we are seeing epidemic of autoimmune issues. And bottom line, babies are not born with a clean slate. Very sad. So here's my questions. Is autoimmune encephalopathy a result of the cumulative stresses and epigenetic changes brought about by the multiple changes in our physical and social environment in the past 100 years? Is autoimmune encephalopathy just one manifestation of widespread chaos in our regulatory systems, but all of those other epidemics of the 21st century, are they also a result of these cumulative stresses and epigenetic changes? Is autoimmune encephalopathy a major issue in the rising incidence of anxiety, depression, and other mood and behavioral disorders, which is, as you all know, another huge, terrible epidemic? And is autoimmune encephalopathy reaching epidemic proportions? Doctors like myself who are seeing these kids, we seem to think so. You know, I just want to point out that a lot of the parents when they come to me, and often these kids have been seen at medical centers, right? And the medical centers refuse to diagnose PANS. And the parents often say, you know, the pediatrician told them, I don't believe in PANS, as if it's a faith-based issue instead of science. You know, we're dependent on you, people like yourselves, raising awareness and making this diagnosis and getting these kids to doctors who know how to treat them. Treatment isn't easy. I mean, some kids turn around quickly and some kids it's a long haul, but they all do improve. You just have to not give up. Okay, and then, yeah, I left this in. This slide was in from a previous time I gave a similar lecture, which was, guess what, around Hanukkah. But I left it in because the miracle of Hanukkah was that we lit a light that was supposed to only last 24 hours, and this little vial of olive oil lasted 8 days while they could press more. Well, you guys are going to be the light going out there, and you're going to have to light a lot of candles, a lot of awareness. It's really, really important. So be well and do good. Thank you very much.